2004, and and seeing the huge change that's happened over the last 15 years in this field. So I'm a hematologist and with a special interest in myeloma and transplant. So I'll be talking. There's a lot of slides, and I'll see how we go with regards to time. As Padman has said, they will be available if required for more detail. And but anyway, I want to cover the themes of the talk, which is short overview. We'll talk about newly diagnosed myeloma, both transplant eligible and non-transplant eligible. I'll pick a few studies to make some points about how we're progressing with immunotherapy in this field. We'll talk about relapsed refractory myeloma and the exciting developments that are happening in that area, and also brief touch on supportive care, which we don't routinely associate with immunotherapy, but there is some exciting developments in that area as well. So if we look at the, I just want to confirm, but the screen's moving okay? And you can see it okay?
Yeah, but I can see. Yes, it's going well.
It's going well. Okay, good.
Yeah.
So if we look at myeloma therapy and progress in myeloma therapy, pretty much modern therapy began in the 60s with the with melphalan and prednisolone, which really nothing was proved to be superior to that simple combination for 40 years, other than the addition of autologous transplant in the 90s. The paradigm shifted in the at the turn of the century with the addition of thalidomide into the treatment armamentarium. And so the proteasome inhibitors and the IMiDs really in various iterations and generations ruled the roost for about 20 years. And it's been the last 5 years that immunotherapy has really taken off. So the immunotherapy revolution started off with daratumumab around 2015, 2016. We've had denosumab, which I'll talk about further in the supportive therapy space. Now we've got a number of agents with isatuximab, ilutuzumab, daratumumab subcut formulation. So the field's progressing very rapidly in the last 5 years. If you look at the immunotherapy options available, there's quite a few. The IMiDs are immunomodulatory agents. We know they have profound actions on the immune system, the microenvironment. And so that already told us about the immune system being very important in the therapy for myeloma, and that we had to look beyond chemotherapy drugs. The other treatment option, which is allogeneic stem cell transplant, we've had that around for 30 or 40 years. And we know that some patients, not a lot, but some patients do benefit long-term from allograft in myeloma, and the effects of donor lymphocyte infusion have been clearly documented in patients with myeloma. So again, there was a pointer towards immunotherapy being effective in myeloma. What's really changed the paradigm is the targeted agents against CD38, SLAMF7 or CS1, which is ilutuzumab. Surprisingly, the checkpoint inhibitors, which have been revolutionary in solid tumor oncology, have not been that effective in myeloma, and it's still not very clear at this stage as to why that is. We've got some antibody drug conjugates targeting BCMA. Again, I'll cover that. The exciting area now is the bispecific T-cell engagers, the BiTEs, and the bispecific NK cell engagers, the BiTEs, and also now we've got adoptive T-cell therapy with CAR T-cells, and CAR NK cells as well, which we'll talk about briefly as well. Now, myeloma vaccines have been trialed for in fact, they were amongst the first immunotherapy options along with interferon, which were trialed in the myeloma field. And they've been around for a long time now. The peptide-based vaccines haven't worked very well. There's been no evidence of efficacy in that area. But in the cell-based vaccines, dendritic cell vaccines may hold a role, and there is a phase 3 trial ongoing, but I won't be covering that today. So if we look at the mechanism of action of immunomodulatory drugs, what I've always find interesting about the IMiDs is that the initial treatment was very empirically based. Nobody knew what the target was. Some laboratory studies had shown evidence of efficacy. That's why the drugs were tried, and they were found to be very effective and caused a paradigm shift away from chemotherapy treatment in myeloma. They have profound actions on the immune system, including actions on NK cells. They prime the action of NK cells against myeloma, and that's been known about for a while, along with actions on the microenvironment. Now, it's only been the last 5 years or so that the cellular target, which is cereblon, has been defined, and which leads to the cytotoxic action of the immunomodulatory group of drugs. But also, we still don't know exactly a lot of the mechanisms of how myeloma targets the immune system, or how it modulates the immune system. And now there is this next generation of drugs called the CELMoDs, which seem to be even more potent. Now, coming to daratumumab, it has the anti-CD38 agent, which has caused the next shift or paradigm shift in myeloma therapy. It has actions, the usual actions of all monoclonal antibodies, CDC, ADCC, and causing direct apoptosis of the myeloma cell. But it does cause profound effects on the immune system as well. And this is particularly seen in the maintenance setting. All daratumumab treatment trials now have maintenance arms, and that is often when the myeloma has already responded, is actually present in very low levels in the marrow or in extramedullary state. So and so that's when the action on the immune system in terms of increase in numbers of helper T cells, depletion of immunosuppressive cells, and clonal expansion of cytotoxic T cells, those mechanisms of actions are important in the maintenance setting. I'm going to talk about that. Daratumumab has been now being added to every anti-myeloma agent, and there are trials with every combination. There's a whole alphabet soup of trials now available, and I'll talk about one of them, which is the Dara VMP study, which is one of the more mature ones. So now we'll move on to transplant eligible newly diagnosed disease. And one of the studies that was presented or has data maturing is the Griffin study, which was presented at ASH last year. So this is a 1:1 randomization between daratumumab RVD versus RVD, four cycles, and then there is both arms get transplanted. There's 2 cycles of consolidation, and then there's a maintenance arm with the Dara arm getting Dara Rev maintenance and versus Rev maintenance alone for 2 years. So this is pretty much RVD transplant, RVD consolidation, and our maintenance would be considered standard of care today. But that's rapidly going to change with the results that we're seeing with the addition of daratumumab, as we'll talk about. The primary endpoint was stringent CR. So now all myeloma trials now, the endpoints are changing, because even a PFS endpoint is often too difficult to show a difference between 2 arms, because the time required for the trial to to run is over somewhere between 5 and 7 years. So if you want to do quicker trials, you have to choose endpoints like stringent CR or MRD negativity, and a lot of myeloma trials are moving towards those endpoints. So these early results from this trial are very promising for daratumumab. So you can see across every time point of myeloma treatment, end of induction, end of transplant, end of consolidation, the dara arm is superior, and there is a stringent CR rate of about 80% at the clinical cutoff, which was about 22 months from randomization. So that to get a greater than CR rate of 80% is exceptional. When you look at the evolution of myeloma therapy, the initial melphalan and prednisolone, we started off with a CR rate of 4%. Now we've got to 80%. So significant progress. I'm not going to talk about cost of treatment here, but at least in terms of just looking at the endpoints of response, we've made significant progress over 40 years. There is a small difference in the PFS curve. As expected, not much difference in the overall survival curve, but a 95% overall survival at the 2-year mark is pretty good, and a 95% progression-free survival at 2 years is also very good. So the take-home message from the study is that this is likely to become the next standard of care for once the results mature. And the problem with daratumumab is logistically it's difficult to deliver because of the frequent need for intravenous therapy, lots of infusion-related reactions, particularly early on. So the PERSEUS study is looking at subcutaneous daratumumab, and we already know that subcutaneous daratumumab is as effective as IV. So once the results of that study come through, it's likely that subcut dara with RVD is going to be the standard of care. Okay, now if we all think that carfilzomib is a more potent drug or a more effective drug than Velcade or bortezomib. So particularly in the second line or relapse refractory setting, carfilzomib is now considered before Velcade in most cases. So it seems to be logical to trial it in frontline therapy. Now, in another discussion today from recent ASCO meeting, I think there were some results of the carfilzomib Revdex versus Velcade Revdex study, which were presented, and there doesn't seem to be too much difference, at least in the frontline setting, between that combination. So it's interesting to see how KRD Dara will compare with VRD Dara. Now there is a phase 2 study which is being done in the US with the KRD combination with Dara, and it's interesting because in this study, the investigators or the treating physicians had the option of whether to transplant or not. All patients received 8 cycles of KRD and Dara, and the patients were not to be transplanted in first line. Now they had a very interesting endpoint, which was MRD negativity after 8 cycles of KRD Dara, and they reached that milestone in 77% of patients. Now that is an amazing number to get close to 80% MRD negative after 8 cycles, and an overall response rate of 100%. I haven't seen a myeloma trial. That is the first trial that I've seen that has an overall response rate of 100%. So this is phase 2 study. The results will not be as good when in a phase 3, but still, it is these are impressive results early on. And again, the MRD negativity seems to be reached in most patients by cycle 6 of treatment. So if you look at limited durations of treatment, if we, as we know, reaching MRD negativity means that patients are going to have a very long progression-free interval. This offers the possibility of limiting the duration of treatment to if most patients are going to get MRD negativity by cycle 8, then maybe that's all the treatment that's required. And then patients could have a long treatment break, and then maybe after 4, 5, 6 years have their next line of therapy. So it's very, very interesting that a lot of interesting questions that the study raises. So there was a summary slide looking at MRD negativity across these various studies, BRD, DARA, and KRD, DARA versus KRD alone. And I mean, look at the Forte study with KRD 8 cycles. With transplant, there is a 58% MRD negativity rate. And this study without transplant, we get 70%, 77% MRD negative. So again, this is every other study which has compared transplant versus no transplant has always ended up in favor of the transplant arm. Maybe with this combination, transplant may not be needed. So that is going to be the next question that's going to be asked. Now, one of the things that amazes me about the role of allogeneic transplant in myeloma is that every few years in the myeloma community, everybody talks about allogeneic transplant being a thing of the past. But then somebody comes up with a new analysis or new study showing that there may still be a role. And so at the last ASH meeting, there was a meta-analysis of 4 trials of auto versus auto-allo in newly diagnosed patients with myeloma. And because all these studies were all done in the 90s and early 2000s, there is long follow-up available, all for relatively younger patients in their with median age in the early 50s, and with different types of conditioning regimens, different types of graft versus host disease prophylaxis. But the slides are interesting, very interesting. As expected, there is a higher non-relapse mortality due to graft versus host disease infection in the auto-allo group. The progression-free survival is not different, and these are survival curves that go out to 10 years, so extended follow-up. At least statistically, there isn't a significant difference in the PFS. But there is, at the 10-year mark, there is a significant difference in the overall survival, 44% versus 36%. And there is a plateauing of the curve. Maybe about 20% of patients are cured with an allograft. I mean, it's an interesting concept. I even though being a transplanter myself, I still transplant very few patients with allograft, very few patients with myeloma now. But it does show that if we hadn't developed all these other therapies in the last 20 years, allograft may still have had a role in myeloma. Okay, so let's talk about the non-transplant eligible group, and we'll come to the ALSAN study, which again is the most mature when it comes to combining daratumumab with the standard of care, which is in the European setting is bortezomib, melphalan, and prednisolone, which has pretty much been a standard for older patients with myeloma in Europe for more than 10 years. And it's good. It's good treatment. It's well tolerated and quite effective. So this study compared 9 cycles of VMP versus 9 cycles of Dara VMP, and then uh, Dara maintenance post Dara VMP with a primary PFS endpoint. So again, this study, because it has a PFS endpoint, is going to take much longer to mature. There were well-matched groups in across both, and about 20%, 15 to 20% high risk in the two arms. Now, this is interesting, the slide of progression-free survival, because the curve starts separating very early on. Now, most studies, if you look at most studies in myeloma, I mean, for example, the first study, which is MP versus Revlimid dexamethasone, the curve starts separating not in the first year, but in the second year, when maintenance therapy with Revlimid seems to make the difference. Here, the curve starts separating very early on. So it's not the maintenance therapy, or it's not in the maintenance area where the difference is. We can start seeing a significant benefit for daratumumab pretty much almost from day one. And if you look at 42-month PFS is 48% versus 14%. I mean, we don't even need to calculate the stats to know that that's significant. And again, the MRD negativity is significantly better in an older group of patients without transplant. To get close to 30% MRD negativity at 40 months is very impressive. Overall survival benefit as well, which this was a secondary endpoint, but significant overall survival benefit, which in these days, I mean, very rarely do you see that in a study. And again, interestingly, for the PFS2, which is progression after relapse, those benefits are maintained longer term as well. So this, again, it looks like we're going to have standard of care daratumumab addition to whichever combination is chosen, VRD, VMP, CVD. Any sort of combination is going to benefit with the addition of daratumumab, and we'll see all those studies read out over the next few years. Okay, let's talk about relapsed refractory myeloma, and that revolution is being led by the agents targeted against BCMA, B-cell maturation antigen. So this is expressed mainly or pretty much exclusively on plasma cells and myeloma cells, and it has different. The amount of BCMA expressed is different, but doesn't seem to correlate with the response rates. So it's like a lot of targeted therapies. We still don't know exactly how much of the target needs to be expressed on the tumor cell for efficacy, and that's similar in BCMA. And BCMA is required for myeloma cell survival, and also has actions on the microenvironment of the bone marrow. So it targets a number of areas where of survival for the myeloma cell. And there's a number of ways in which it's being used as a target. So this is a study where I'm an investigator. It's called the DREAMSIC study, where belantamab mafodotin, which is a drug antibody conjugate, is being used in combination with lenalidomide or bortezomib in the study. Now, the phase 1 single agent studies with this agent, which is called Belmaf now, has shown initial phase 1 study, it's shown an exceptional overall response rate of 60% in very heavily pretreated patients. The phase 2 study, which led to its registration in the US, has possibly a more realistic response rate of about 30%. But again, in heavily pretreated patients, these are proteasome inhibitor and IMiD refractory and previously treated with a CD38 antibody, to get a response rate of 30% is pretty good. So could that be improved with combination? That's what this study is looking at. It's a dose escalation study in combination with bortezomib and lenalidomide, and the results of the combination with bortezomib were presented at ASCO. ASCO just gone. Now, the interesting thing with I'm finding with all drug antibody conjugates is that they have some often unexpected toxicities. With in the hematologic cancer space, with brentuximab, there was neuropathy. With gemtuzumab ozogamycin, in AML, there was hepatotoxicity, and this agent has a toxicity on the cornea. So it causes a keratopathy, and that is, at least practically, a difficult area to manage, because you have to give a lot of treatment breaks to these patients. So future development of this molecule is being there's going to be different dosing schedules and possibly combinations with other agents which might help with this toxicity. So a significant number of patients had in the DREAM2 study, 69 out of 85 had keratopathy. So it is something that we will need to manage going forward. But the response rates are pretty good. So 80% overall response rate when combined with bortezomib. Now, the eligibility for criteria for this trial had patients across anywhere from one prior line of therapy to any number of prior lines of therapy. So it's a pretty heterogeneous group of patients, but still there's at least the early data is quite encouraging, and we're hoping that we'll present the lenalidomide data in ASH in December. So there are other agents in this space as well, which the early studies are starting to recruit now. So it'll be an interesting area to see how it will stack up against this next group of agents, the BiTE antibodies or the bispecific T-cell engagers. Now, these agents are designed to overcome the immune surveillance or the failure of immune surveillance, which happens in myeloma. And like all BiTEs, they attach the tumor cell to a T cell, which causes expansion of the T cells, and these induce apoptosis of the tumor cell. So this is the first in-class molecule called AMG 420. And like blinatumomab in ALL, this has to be given as a continuous infusion for 4 weeks, which is pretty difficult logistically. And this is the study which was the phase 1. And it did show a very good response rate, overall response rate of 70%. Again, with some MRD negative patients. Now, these are very heavily pretreated patients, and to see responses which are MRD negative is again has only been seen in the immunotherapy space. None of the PIs and IMiDs were able to do this. So obviously, we are seeing responses which we have never seen before in myeloma. Now, the next agent also from Amgen is 701, which has a once in 3 week dosing schedule. And there's a largish phase 1/2 study recruiting. And we're doing that study. And we have seen, again, exceptional responses in patients who have had 7-8 lines of therapy prior, autologous allotransplant, everything. No therapy remaining have gone on to this study and have had MRD negative responses maintained for more than 2 years. So one of my patients has now been MRD negative for more than 2 years on this study after 8 prior lines of therapy. So I think this is the agent which is likely to move forward because it's got a much more convenient dosing schedule. Now there are other agents in this space. This was another agent whose results were presented at ASH. They call it a 2+1 because it's got a bivalent anti-BCMA. It targets BCMA in a bivalent mechanism, and it's supposed to be more potent. And it has one epitope which does not bind to complement, which is the other BiTEs do, and this may help with reducing toxicities such as infusional toxicities. They presented early results of this agent. Again, it's delivered on a day 1, 8, 15, 22 schedule, which is more convenient than a daily or a continuous 28-day dosing regimen. And this is the safety slide. You can see that these agents are pretty potent, and we have to learn to manage toxicity because there is one grade 5 CRS toxicity here. Now, that's a treatment-related death, and it just shows how potently these agents stimulate the immune system, that you can get a grade 5 event from immune stimulation. The majority of events are grade 1 and 2, so and manageable with using steroids and occasionally need tocilizumab. But this is something that we will have to learn to manage along the way with these agents, is the CRS. So you can see here 75% of patients needed corticosteroid use, and about little less than half needed tocilizumab. Now, this was a dose escalation study, so as the more effective doses have been reached, 11 out of 13 patients responded, and those responses are being maintained longer term. This is the other thing with the BiTEs, which, as we talk about when we talk about the CAR T cells, is that the responses in the patients who respond, a lot of them maintain their responses long term. So again, the take-home message from the patients when the more effective doses are being reached, we're seeing overall response rates of close to 90% with the 44% stringent CR or CR rate. Okay, let's talk about the CAR T cell space, which I left this for last because I mean, everybody only wants to talk about CAR T cells these days, but in the myeloma space, it comes with a lot of caveats. They are very effective, but there are caveats. So let's. I'm not going to go into the constructs or and all that information is out there and it's now well commonly known. But this is the most advanced CAR in myeloma, which targets BCMA, and it's BB2121. All of them are unpronounceable names, so I'm not going to try and pronounce it. But it's got the anti-BCMA tumor binding domain with a transmembrane CD8 linker and a co-stimulatory 4-1BB domain, which is linked to the CD3 zeta. So that's pretty much all CARs are constructed like this, and there are differences in the co-stimulatory domains and obviously the tumor binding domains. Now, the three studies in myeloma which are the most advanced in their recruitment are summarized here. They're all very heavily pretreated with between 5 and 6 lines, median prior lines of therapy, significant numbers of extramedullary disease, which is always a marker of more difficult myeloma, more advanced myeloma, and significant tumor burden. There are differences in their constructs, differences in their cell doses. they all have issues with cytokine release syndrome, and the next two agents in the pipeline, the which is in the Cartitude-1 and the Janssen molecule, and the orvacaptogene, which is the Evolve study, they seem to be more potent, and so the CRS and the neurological events are maybe more of an issue in these with these agents. They also cause HLH or hemophagocytosis or macrophage activation syndrome, and particularly these the second and third agents in the pipeline, they seem to be more prone to these problems, and therefore you can see more use of steroids and tocilizumab as compared to BB2121. But this is, I suppose, the important slide where we've got stringent CR rates of 86% with the Janssen CAR in the Cartitude study. Now that, again, for 6 prior lines of therapy is an amazing figure to get 86% greater than CR rate and 81% MRD negativity. So encouraging response rates. But what I've not shown is the progression-free survival curve. In the BB2121 study, which has the most patients, more than 120 patients in the KarMMa-1 study, most patients have relapsed at a year. So there's no plateauing in the curve. So that is a problem. And at least in the myeloma space, different strategies will need to be evolved to deal with this high rate of relapse. There are numbers of studies going on. They're summarized in that slide. Now, to address that problem of relapse, there is this next construct, which is BB21217, where the cells are cultured with the PI3 kinase inhibitor, and this produces a product which has a memory phenotype, more of a memory-like phenotype, which may improve persistence of the CARs and hopefully improve the progression-free interval. There's a number of other targets in preclinical development targeting CD70, CD56, 38, 138. There's a whole lot of targets that are being developed. We'll just talk a little bit about the details of these studies. So the slide that I showed with the summary slide with the Janssen CAR T cell was originally developed in China. It was, I think the company was called Legend. And this was interesting because the Chinese study that was the first to use this construct was actually in patients who were not as heavily pretreated. And there were certain other differences there. Leukodepletion step only has cyclophosphamide. Pretty much across most CAR T cell studies, the leukodepletion uses fludarabine and cyclophosphamide. This one had only cyclo. And when we look at the patient population, as I said, the median prior lines of therapy was only 3, as opposed to 5 to 6 in the other studies. And a lot of the patients had only exposure to either an IMiD or a PI only. So they were not as heavily pretreated. And only less than 20% had a prior autograft. And so when we look at the results of that study, it's showing a 74% response rate or complete response rate with a reasonable number of patients, 57, with nearly 70% MRD negative. So, and those responses are being maintained over a period of time. So median duration of response in patients with CR is 29 months. So it does look like if the CARs are used early on in myeloma treatment, they may be more effective. I suppose that holds true for any treatment in oncology. So it's interesting to see this phenomenon. But the other interesting thing is that, and that again, when you look at most CAR T cell study data, CAR Ts don't seem to, at least are not detectable long term in the blood or tumor compartment or wherever you're studying it. So again, here only 4 patients had CAR T cells in the blood for more than 10 months, but still continued to maintain the response. So, and so these are the survival curves which show that at 30 months, the PFS is nearly 50% if you achieve a CR. If you don't achieve a CR, you will progress in less than a year. So the key is to get that CR. And then this was taken forward into this CARTITUDE. The same construct was taken forward into the CARTITUDE study in the US. And these patients were in their inclusion criteria, they were more heavily pretreated. They had to have a prior PI, IMiD, and anti-CD38. And so there were patients with 3 to 18 lines of therapy. I still struggle to work out how someone can receive 18 lines of therapy, but it's there. And majority of the patients are getting grade 1 to 2 CRS events, but manageable. And there is again one grade 5 event here, so that a note of caution is always required. But there's a waterfall plot which an investigator would only dream of, where everybody has responded and the majority have had a complete response. So that is very, very encouraging. And this is just some more response data. And a significant number of patients were MRD negative, depending on what level of MRD was chosen. Or even if you choose the highest level of MRD, 10 raised to minus 6, more than 50% of patients were MRD negative at that level. So this holds a lot of promise. Now, I'm going to skip these slides in the interest of time, but this is just from the 21217 study, which we hope will, the CAR T cells will last longer in the blood and produce more prolonged responses. And so again, in this study, as the higher doses or the more effective doses of cell doses are reached, most patients respond. And these, at least at those levels, the progression-free survival curves and the probability of response improves. There are some, as I mentioned earlier, some other targets being studied on CD19, CD138. The CD19 target, like in lymphoma, you can see some responses there. The other two, CD138 and the light chain targeted CAR Ts, there's some stable diseases, but not as, at least when compared to 100% responses with the BCMA CARs, doesn't seem that encouraging in early data. Now, lastly, to end with, I'm just going to talk about denosumab. So it's always interesting to me that about development of myeloma therapy, the first big change that we saw when it came to supportive care was when zoledronic acid became standard of care for management of skeletal related or prevention of skeletal related events. But the Myeloma 9 study, which led to that change, was a study which I've recruited patients to. And it was interesting because that study was only designed to work out a benefit for skeletal related events. But when the survival data was looked at, there was a difference in survival, an improvement in survival for patients who received Zometa versus those patients who received clodronate. And that actually became the biggest reason for a shift to, there was some difference in the skeletal related events as well as compared to clodronate. But the difference in survival between the two arms really led to the Zometa becoming the standard of care. So this study was designed to look at, as a non-inferiority study, to look at denosumab versus Zometa in myeloma for skeletal related events. And because it was a non-inferiority study, it was very large. 1,700 patients recruited, more than 850 in each arm. And again, there's no difference when it comes to skeletal related events. The two agents are comparable. But again, when the survival curves were looked at, there was a difference of about 10 months between the denosumab arm and the Zometa arm. And when those groups were subdivided in various ways, in the transplant subgroup, that difference was maintained, and that difference could not be explained by prior therapy or induction therapy for the myeloma, which was pretty similar across both arms. So it is very interesting that another agent, another monoclonal antibody, which targets the microenvironment, which its primary aim is to prevent skeletal related events, may have some impact as an anti-myeloma agent as well. And so this may mean that going forward, denosumab may become the agent of choice, which again emphasizes the importance of the immune system in myeloma. So that is my last slide, and I was fortunate enough to see Usain Bolt run in Melbourne. This was a year after he'd retired. He came here and did an exhibition event, and we waited for 2.5 hours to see him. And when we did actually see him, it was for a few seconds, but it was worth it. It was worth the wait. And I always think that's parallel to what we know about in terms of immunotherapy. We waited for more than 50 years to see these agents in myeloma, and now they're taking off like Usain Bolt is. And I think this next decade will be all immunotherapy in myeloma. Thanks for listening, and I'm happy to take any questions.
Yeah, thank you very much, Amit. That was quite exhaustive and still a very lucid talk, which summarizes things which are happening in this field. A lot of people have a difficult time. There's an explosion of knowledge in myeloma as well as in solid tumors, especially in immunotherapy, and people have been struggling hard to keep pace with whatever is happening. So you've done really a good job in summarizing things in this field. I don't think people have any question. It means either they have understood everything or probably they haven't understood anything. We have one question. So it's from Rohan. Do you feel that autologous transplant will be pushed to relapse